Hello everyone and welcome to our module on thyroid hormones. Okay, in this video we're going to talk about the thyroid hormones, which are hormones produced by the thyroid gland in the neck. You'll notice that this video is a little bit basic science-y for a Step 2-3 clinical video, but I've done it this way on purpose because if you understand some of these fundamentals about how thyroid hormones work, it's much easier to understand the disease states that we'll talk about in other videos. So there are two thyroid hormones. The first is triiodothyronine or T3 and the second is thyroxine or T4. Both of these hormones are synthesized from the amino acid tyrosine, which is shown here on the screen, and the chemical element iodine. If you look at the bottom of the screen, this is the structure of T3. It's called T3 because it has 3 iodine molecules in it. This is the structure of T4, called T4 because it has 4 iodine molecules in it. So as we just saw in the last slide, thyroid hormones contain the chemical element iodine. And so in order for our thyroid gland to be able to produce thyroid hormones, we have to consume iodine in our diet. There are a number of sources of iodine, but an important one, especially in the United States, is iodized salt. When you buy table salt, which is sodium chloride in the United States, it usually comes mixed with a small amount of iodine. This is called iodized salt. And many countries, including the United States, do this in order to prevent iodine deficiency. Since 1924 in the United States, table salt, sodium chloride, has been sold as iodized salt mixed with iodine, and ever since that's been done, the incidence of iodine deficiency has been very, very low in the United States. Now, when you consume iodine in your diet, in order for thyroid hormone to be produced, the iodine has to undergo a couple of changes. First of all, it has to be oxidized to form I2. This is called oxidation. And then it also needs to be added to organic or carbon structures. This is a process called organification. In order for iodine to undergo those processes and be incorporated into thyroid hormone, the thyroid gland requires an enzyme called thyroid peroxidase or TPO. This is a multifunctional enzyme. It catalyzes several different steps in the synthesis of thyroid hormones. It's responsible for the oxidation of iodine. It's also responsible for organification of iodine into substances called MIT and DIT. I'll talk about these more in a minute. And it can also couple together molecules of MIT and DIT to form the T3 and T4 thyroid hormones. And then besides these physiologic roles in production of thyroid hormone, antibodies to TPO occur in autoimmune thyroid disease, which I talk about in different videos. And detection of those antibodies is sometimes used as part of the diagnosis of autoimmune thyroid disease. So as I said earlier, producing thyroid hormones like T3 and T4 begins with the amino acid tyrosine plus iodine. So TPO can bring 2 iodine molecules together to form I2. It can then catalyze the organification process where iodine is added to carbon structures. This can produce molecules of MIT, which is monoiodotyrosine. This is a tyrosine molecule with a single iodine attached. It can also produce molecules of diiodotyrosine or DIT, which is tyrosine with 2 iodines attached. And then TPO also can catalyze the combination of these molecules here to finally form either T3 or T4. Let's talk about thyroglobulin, which is a protein that's produced by follicular cells found in the thyroid gland. Thyroglobulin is a large protein that has numerous tyrosine molecules attached to it. And so these molecules get converted into MIT and DIT, and then T3 and T4, and then they are released as T3 and T4 hormones. So basically, thyroid hormone is produced attached to thyroglobulin in the thyroid gland. And from a clinical point of view, there are thyroglobulin antibodies that occur in autoimmune thyroid disease, just like there are anti-TPO antibodies that can occur. Most of the hormone that's produced by the thyroid gland is thyroxine or T4. Over 90% of the thyroid hormone produced by the thyroid gland is T4. However, T3 is the more potent hormone, and what happens is in peripheral tissues there is an enzyme called 5'-deiodinase. This enzyme can remove an iodine molecule from T4 to create a molecule of the more potent T3. So the key point here is that the thyroid gland mostly produces T4, but then lots of that T4 is converted to T3 in peripheral tissues by the enzyme 5'-deiodinase. Let's talk about the Wolff-Chaikoff effect. So because iodine is part of thyroid hormones, If you consume excessive iodine in your diet, this could lead to hyperthyroidism. In other words, all that iodine could get converted into thyroid hormone, causing symptomatic hyperthyroidism. But this doesn't happen because of a physiologic phenomenon known as the Wolff-Chaikoff effect. This is how the thyroid gland protects itself from causing hyperthyroidism when excessive iodine is consumed in the diet. So when the iodine levels get too high in the thyroid gland, this inhibits synthesis of thyroid hormone. Organification, that process I talked about earlier, is inhibited by high iodine levels in the thyroid gland, and this leads to less synthesis of MIT and DIT. This is just a temporary effect, and normal patients with a normal thyroid gland will escape from this effect over time and will have a brief decrease in thyroid hormone production when there is an excessive iodine level in the body. In some thyroid diseases, which I talk about in other videos, there is a failure to escape from the Wolff-Chaikoff effect. What this means is that iodine in the diet or maybe in a drug that the patient is taking leads to prolonged decrease in hormone production from the thyroid gland, and that leads to clinical features of hypothyroidism. This is the way the antiarrhythmic drug amiodarone can cause hypothyroidism. Amiodarone contains iodine, and it can suppress thyroid hormone production due to failure to escape the Wolff-Chaikoff effect. You can also see this in some patients with certain forms of autoimmune thyroid disease. There's also a phenomenon that can occur in disease states called the Jod-Basedow phenomenon. This happens when there is no Wolff-Chaikoff effect and excess iodine leads to hyperthyroidism. This can occur in patients who have toxic adenomas in the thyroid gland, which I talk about in another video, but those toxic adenomas do not have the Wolff-Chaikoff effect, so if patients consume iodine in any manner, this can lead to hyperthyroidism, and this is called the Jod-Basedow phenomenon. Let's talk about how the production of thyroid hormone is regulated. So the hypothalamus releases a hormone called thyroid releasing hormone, or TRH. It stimulates the anterior pituitary gland to release thyrotropin, which is called TSH. TSH can stimulate cells in the thyroid gland to produce thyroid hormones, including T3 and T4. And as we talked about earlier, the majority of the thyroid hormone produced by the gland is T4. T3 and T4 can then feed back on the pituitary gland and the hypothalamus to decrease the release of TRH and TSH. And these things are all depicted in this image on the screen. This is TRH coming from the hypothalamus. It stimulates the pituitary to release TSH. That stimulates the release of thyroid hormones, which provide negative feedback to the pituitary gland and the hypothalamus. Let's talk about thyroxine binding globulin, or TBG. So thyroid hormones are poorly soluble in water and therefore in plasma. So they circulate bound to TBG, which is a large molecule produced by the liver. Most of the thyroid hormone that you find in plasma is T4 because, as we talked about earlier, this is the principal hormone produced by the thyroid gland. And almost all of that T4 is found bound to TBG. The T4 that's bound to TBG does not exert hormone effects because it's bound to the carrier molecule. What does produce the hormone effects is a small amount of free T4, which is found in the plasma in equilibrium with the bound T4 that is bound to TBG. So when we want to assess thyroid function in a patient, we send a series of lab tests known as the thyroid panel, and it includes 4 standard measurements of thyroid function. The 4 measurements are the TSH level, the total T4, the total T3, and the free T4. I've shown the normal ranges on this slide, and I just want to point out a couple of things that hopefully make sense to you based on what we've been talking about. Notice that the total T4 level is much higher than the free T4 level, and that's because, as we talked about, total T4 includes all that T4 that's bound to TBG. Notice also that the concentration of T4 is much higher than T3, and that's because the principal hormone produced by the thyroid gland is T4, not T3. A super high yield thing to know for your board exams is that the liver increases its production of TBG anytime there are high estrogen levels in the body. So this happens in women who are pregnant. They have lots of estrogen around. It can also happen in women who are taking estrogen-containing contraceptives or hormone replacement therapy. All of these things, because they involve high levels of estrogen, will cause the TBG level to go up, and that will raise the total T4. The TSH and the free T4 will be normal. These women do not have thyroid disease, but they have a high total T4 level, and that's because of the high levels of estrogen. To understand this better, let's look at this diagram I've created on the screen. So in women in high estrogen states, there's a rise in TBG production from the liver. As more TBG is produced, there's more bound T4. In other words, the free T4 ends up getting pulled out of the plasma and bound to TBG. So this leads to a temporary and brief fall in the T4 level, which causes a temporary and brief rise in the TSH level. Because the TSH level goes up, the thyroid gland starts producing more T4 and you get a rise in the total T4. Now, when the total T4 level goes up, that also raises the free T4 back to normal, and that in turn brings the TSH level down back to normal. So what this whole thing means over here is that in women who are in high estrogen states, they will have an elevated total T4 caused by the rise in TBG. They will, however, have a normal TSH and free T4, and this means that they don't have thyroid disease. They just have a high estrogen state. So a classic board question is a woman who has a high total T4 but normal TSH and free T4, and they ask you if she has thyroid disease. She does not. She just has high estrogen levels around, usually from one of these things shown on the slide here. Changes in TBG levels are only one of the changes that occur involving the thyroid hormones among women during pregnancy. If you look at this graph on the screen here, we've got time during pregnancy along the x-axis, and the different lines represent the changes that are occurring in various thyroid hormone levels. One of the things that happens during pregnancy is there's a rise in TBG levels driven by high estrogen levels, and this will lead to an increase in the total T4 level, just like what we talked about in the last slide. And that's what these two lines here are showing. The levels of TBG and total T4 climb in early pregnancy and then plateau, and this is all driven by estrogen. But a second phenomena that occurs during pregnancy is that HCG levels are very high in early pregnancy before about week 20, and HCG can stimulate the thyroid gland to produce more thyroid hormone. That's because HCG has the same alpha unit in the hormone as TSH, and therefore HCG has some TSH-like effects on the thyroid gland. So this rise in HCG levels in early pregnancy will cause the thyroid gland to produce more free T4, and therefore free T4 levels go up in early pregnancy, and because the free T4 level goes up, the TSH level declines. When the pituitary gland senses higher free T4 levels, the pituitary decreases its production of TSH. And that's what you see here shown in these red and blue lines in early pregnancy. This is all driven by the high levels of HCG. HCG levels then fall by about week 20, and then these changes in free T4 and TSH begin to resolve later in pregnancy. For the remainder of this video, I'm going to talk about thyroid hormone effects on different organ systems in the body, and it's essential to understand these things in order to understand hypo and hyperthyroidism, which I'll talk about in other videos. So thyroid hormones are major regulators of metabolic activity in the body and also growth. They regulate glucose and lipid metabolism and also cardiac function. They're also important for normal bone growth and normal CNS development. In terms of metabolic effects, thyroid hormones increase carbohydrate metabolism. And what I mean by this is that they increase the rate of glycogen breakdown in the liver. This is glycogenolysis. They also increase the production of glucose from the liver through gluconeogenesis. So because of both of these effects, thyroid hormones raise the serum glucose. That's a normal effect of thyroid hormones. They also increase lipid metabolism. And what I mean by this is that they reduce the concentrations in plasma of cholesterol and triglycerides. They promote the excretion of cholesterol in the bile. They also increase LDL receptors in the liver, which pulls LDL from the plasma. So in terms of clinical medicine, what this means is that hypothyroid patients will have high plasma cholesterol. So in any patient with a new diagnosis of hyperlipidemia, we often check the TSH, and that's because we want to exclude that the patient might have hypothyroidism causing their high serum cholesterol values. Also, because of these metabolic effects of thyroid hormones, when patients are hyperthyroid, they usually have hyperglycemia, and that's because of the raising of serum glucose caused by thyroid hormones. Some other metabolic effects of thyroid hormones are that they raise the basal metabolic rate. This is the basal rate of energy use per time by the body. It's essentially the amount of energy you would burn if you slept all day and performed no activity. Thyroid hormones raise this rate, and they are responsible for keeping it normal. One of the major ways that thyroid hormones raise the basal metabolic rate is by increasing the number of sodium-potassium ATPase pumps found on cells in the body. Thyroid hormones cause more pumps to be present in cells, and that leads to more consumption of ATP by the body in general, and this is going to raise the basal metabolic rate. This also increases the oxygen demand because cells need to replenish the ATP they are consuming, and for this reason, thyroid hormones cause the respiratory rate to rise. They can also raise the body temperature because they cause more ATP consumption. And so clinically, what this means is that patients who are hypothyroid tend to gain weight because their basal metabolic rate is low. In contrast, patients who are hyperthyroid tend to lose weight, and that's because their basal metabolic rate is high. In terms of cardiac effects, thyroid hormones increase the number of beta-1 adrenergic receptors found on cells in the heart. And because they do this, thyroid hormones can lead to a rise in cardiac output and a rise in heart rate. So clinically, what this means is that hypothyroid patients tend to be bradycardic because they have very few beta-1 receptors on cells in their heart. In contrast, hyperthyroid patients tend to have tachycardias or arrhythmias, and these are caused by too many beta-1 receptors found on cells in the heart. In terms of bone effects, thyroid hormones increase bone turnover. They stimulate the resorption of bone. So this is mainly a problem in patients who have hyperthyroidism. They tend to have too much bone resorption, and this can lead to osteoporosis. It can also lead to hypercalcemia. And then lastly, thyroid hormones are required for normal bone growth and central nervous system maturation as children are growing. So it's rare, but if a child has hypothyroidism, this can lead to a clinical syndrome called cretinism. Children with cretinism have stunted growth and intellectual disability. They also classically have a large tongue and an umbilical hernia like shown in this drawing on the screen here. And cretinism due to childhood hypothyroidism is very rare, but it does occur in parts of the world where there's iodine deficiency and children don't get enough iodine in their diet. It also can rarely occur if children are born with congenital forms of thyroid disease and they're unable to synthesize thyroid hormones. And that concludes our module on thyroid hormones.